This is a CJSON podcast and I'm Hiddo Heerspink from the University of Groningen, the Netherlands. I'm privileged to have the opportunity to inform you about our new study on the effects of the SGLT2 inhibitor Canagliflozin in slowing progressive kidney function loss according to the degree of glycemic control. In the Credence trial, the SGLT2 inhibitor Canagliflozin improved kidney and cardiovascular outcomes and reduced the rate of GFR decline in patients with type 2 diabetes and CKD. Analyses of more recent large kidney and cardiovascular outcome trials demonstrated that the effects of SGLT2 inhibitors on GFR decline are more pronounced in patients with type 2 diabetes compared to those without diabetes. This was, for example, observed in patients with chronic kidney disease who participated in the DAPA-CKD trial. In addition, in patients without CKD without diabetes, the albuminuria lowering effect of SGLT2 inhibitors are less pronounced compared to patients with type 2 diabetes, suggesting that the degree of glycemic control may modify the benefit of these agents on kidney surrogate endpoints such as GFR decline or albuminuria. Whether the dependency of these effects on HbA1c can be detected in an exclusively type 2 diabetes population with varying degrees of glycemic control is unknown. We therefore performed a post-hoc analysis of the Credence trial to address this topic. As you probably know, Credence was a randomized, double-blind, placebo-controlled, multi-center clinical trial in adults with type 2 diabetes who had an HbA1c between 6.5 and 12% and a GFR between 30 and 90 mL per minute. Participants were randomly assigned to Canagliflozin 100 mg once daily or placebo. The trial demonstrated that Canagliflozin compared to placebo reduced the risk of the primary kidney outcome of doubling of creatinine, kidney failure, or death due to kidney or cardiovascular cause by about 30%. In this post-hoc analysis, we studied the effect of Canagliflozin on GFR slope using linear mixed effects models and created subgroups of baseline HbA1c using the following thresholds: HbA1c between 6.5 and 7, 7 to 8, 8 to 10, and 10 to 12%. We found in the overall population that the annual decline in total GFR slope was 1.5 mL per minute per year slower in participants randomized to Canagliflozin compared to placebo. The rate of GFR decline was faster in those with poorer baseline glycemic control. The mean difference in total GFR slope between Canagliflozin and placebo was also greater in patients with poorer baseline glycemic control. Specifically, for the defined HbA1c subgroups, 6.5 to 7, 7 to 8, 8 to 10, and 10 to 12%, the difference in GFR slope was 0.4, 1.4, 2.6, and 1.6 mL per minute per year. The mean difference in change from baseline in UACR between participants randomized to Canagliflozin and placebo in patients with baseline HbA1c between 6.5 and 7% was 17%, compared to 32% in those with an HbA1c above 7% at baseline. When analyzing the primary kidney endpoint, there was no evidence that the effect of Canagliflozin varied by baseline HbA1c. These data thus confirm previous studies demonstrating that the rate of kidney function decline is faster in patients with type 2 diabetes and poorer glycemic control. In addition, these new data also suggest that the effect of Canagliflozin in slowing the rate of kidney function decline is more pronounced in patients with a poor glycemic control. Interestingly, the effect of Canagliflozin on the primary kidney endpoint did not vary by baseline HbA1c. These differential effects on the surrogate and clinical outcomes may be explained because the effect of a drug on clinical endpoints are determined by the number of patients who reach the event. In a clinical trial of 2.5-year duration, such as Credence, these are patients with a rapid decline in kidney function who have higher HbA1c values. In contrast, the effect of canagliflozin on GFR slope is determined in all patients, both slow and fast progressors. It is possible, however, that among patients with a nearly normal HbA1c, who on average have a slow decline in kidney function, there are still some fast progressors, those with near normal HbA1c and high albuminuria, in whom canagliflozin prevents clinical events. These data are now published in CJation, and I hope you find these of interest.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.